Okay, welcome everyone. So pleased to have so many of you joining us tonight virtually on this beautiful evening. My name is Brittany Cadence. I am the Communications Manager here at Peterborough Public Health. I'll be your MC this evening for tonight's event. I'm very pleased that you can join us for this update on the latest COVID-19 vaccines. And our presenter tonight is the indefatigable Dr. Rosana Salvatierra, Medical Officer of Health for Peterborough Public Health. And before we get into the presentation, we just thought we'd take a moment as we gather here this evening to recognize this beautiful place we call home with a land acknowledgement. We respectfully acknowledge that Peterborough Public Health is located on the Treaty 20 Mississauga territory and in the traditional territory of the Mississauga and Chippewa Nations, collectively known as the Williams Treaties First Nations, which include Curve Lake, Hiawatha, Alderville, Scugog Island, Rama, Beausoleil, and Georgina Island First Nations. Peterborough Public Health respectfully acknowledges that the Williams Treaties First Nations are the stewards and caretakers of these lands and waters in perpetuity, and that they continue to maintain this responsibility to ensure their health and integrity for generations to come. We are all treaty people. So with that, we will get underway, and at the end of Dr. Salvatierra's presentation, if there's time, we will attempt to answer some of the questions. So feel free to put them into the chat box on the YouTube stream, and then I will read them out for Dr. Salvatierra. So with that, I will move on and introduce Dr. Salvatierra. Go ahead.
Thanks so much, Brittany. Hello, everyone. It's a pleasure to be with you tonight. And we're here to talk about two new vaccines that have been authorized in Canada. One is the Astrazeneca vaccine, and the other is the Jansen. They have a lot in common, and we'll go through that in just a moment. And they have some differences. First of all, the Astrazeneca is a 2-dose vaccine with doses between 4 to 12 weeks apart. And the Jansen vaccine is the first one that is a single-dose vaccine, which is very exciting. Both of the vaccines have been authorized in Canada for people over the age of 18. So that makes it 4 now. We have 4 COVID-19 vaccines that have been authorized. So I'm going to spend the next 30 or 40 minutes going through these two new vaccines and answering some of the questions that you've sent in. And then, as Brittany said, we'll get to your questions as well. So let's get started. So what's different or better about these two new vaccines? Well, first of all, you may not care, but we care. These vaccines are refrigerated vaccines and they're not frozen, which means that they can be kept in inspected fridges in healthcare settings and in pharmacy settings. They're stable and they're much more easily moved and used. That makes a big difference for us. They both use the same kind of vaccine technology. They use a virus or an adenovirus, the common cold virus, to carry the spike protein into the muscle cells. And as I said earlier, the differences are that the AstraZeneca is a 2-dose, but the Janssen is a 1-dose, which when you think of the amount of work, we are essentially undertaking the largest vaccine rollout in Canadian history. And because most of the vaccines are 2 doses, we're doing it twice. Being able to use a 1-dose is much, much easier. And so we really are looking forward to having this product. Next slide, please. So how do they work? Well, essentially, the adenovirus acts as the shuttle or the delivery truck. It carries the protein gene into the cell. So the AstraZeneca vaccine uses a chimpanzee adenovirus because one of the problems when you use adenoviruses is that they're so common, most of us have antibodies against them. So when you're using an adenovirus vector, you have to use one where the immune system is not already activated. So these two vaccines use two different viruses. One is using a chimpanzee virus that doesn't infect humans, so none of us have antibodies against it. And the other one, the Jansen, uses a more rare adenovirus. It is a human adenovirus, serotype 26. But what they've done is they've altered the virus. They've removed the gene that allows this virus to replicate. So it cannot replicate in your body. What happens is the viruses bring the gene into your cells. Your cells make the spike protein. The spike protein triggers the immune system, and therefore you now have an immune system that's activated against the spike protein on the COVID-19 virus. Next slide, please. So just a reminder here before we're going to do a little bit of a review tonight, as well as focusing in on these two new vaccines. There you see before you, you see the COVID-19 virus, and those orange little spikes, those are the spike protein. And you can see that that spike protein is the piece that connects to the ACE2 host receptor in your cells. And when they make that connection, it unlocks the door and the virus gets into your cell. It infects you. And there to the right, there's an anti-spike protein antibody. And when you've got those in your system floating around, they recognize that spike protein and they block it. So then you cannot get infected. So that's essentially how all of the vaccines work. Next slide, please. So there are two steps in making the spike protein, and we're going to start at the bottom of this slide. So what you'll see is some DNA, and the DNA is the first step, because DNA essentially what it does is it codes for all the different proteins in your body, in a virus's system, and so that's really the backbone. And the first step of making a new protein is that the DNA needs to get copied onto a messenger RNA, and that piece you'll see is called transcription. So that's the first step. Once the messenger RNA has now copied that recipe, it then travels to the ribosome, which is your kitchen or your protein factory in your cell, and it translates that recipe into a protein. So what happens is that the ribosome makes that protein, and that protein floats up to the surface of your cell. So those are the two steps involved in making a protein. Next slide, please. So with the messenger RNA vaccines, and these are the Pfizer and the Moderna vaccines, they supply that translation step. They actually give that, they provide that messenger RNA that floats up into your ribosome that then becomes the new protein. And so that's how they work. The problem with the messenger RNA vaccines is that they're very unstable. And that's because you see that envelope around it, that lipid nanoparticle that surrounds that messenger RNA, that's very, very fragile. And so because it's so fragile, it needs to be kept frozen, and you can't shake it, and you have to be very careful when you move it. Okay, so those are the Pfizer and the Moderna vaccines. Next slide, please. And this shows how they work. Okay, so you see there's the vaccine coming in as a nanoparticle, carrying the messenger RNA into the cell. That nanoparticle dissolves, releases the messenger RNA, which travels up into the ribosome, provides that recipe for the protein, the spike protein, and then your cells make that spike protein, which then triggers the immune system the cellular and humoral parts of your immune system so that you now are protected against the COVID virus. Okay, now let's take a look at how these new viral vaccines work. Let's look at the next slide, please. So the Astrazeneca and the Jansen vaccines, they do the same thing, essentially. They just do 2 steps instead of 1 step. And what they do is that the virus, and you can see it at the top, the adenovirus comes into the cell carrying the gene, and the gene is to make the spike protein, and it drops the gene into the nucleus, okay, and it's sort of like parking a car into the garage. It drops it off there, and then your own messenger RNA says, oh, there's a new little gene here. Let's make a copy of it. And it takes the recipe from that gene and it carries it to the ribosome, and the ribosome makes the spike protein. So, and then it floats off to the surface. There you can see them on the surface, and it does the same thing. It triggers the immune system. So very similar, but also some real differences in how these 2 vaccines work. Next slide, please. So you may have some questions already as I've been talking. First of all, can the adenovirus, it's a virus, can it cause disease in me? And the answer is no. The chimpanzee adenovirus does not cause disease in humans. And as I said earlier, the serotype 26 adenovirus that's used in the Jansen is altered. So it can't replicate inside the human body, and it cannot cause disease. But both adenoviruses, and this is why adenoviruses are used in vaccines, they are very immunogenic, and they really rub your immune system the wrong way, and they get it going so that your immune system makes both the B cells and the T cells that you need for a really good response. And when you get your vaccine, when you're feeling a little achy or your muscles hurt those first few days after you had a vaccine, that's what's happening. Your immune system, those muscle cells that now have the spike protein on them, are triggering your immune system. So that actually tells you that it's working. Next slide, please. Can I get COVID-19 from these vaccines? Well, the answer is no, because they don't contain either dead or altered or live COVID-19 viruses. They are COVID-free vaccines. All they contain is either the gene or the mRNA for the spike protein, the instructions or the recipe for that spike protein. Next slide, please. Will these vaccines alter my DNA? After all, they're dropping this little piece, this gene, into my nucleus. Should I be worried? Well, the answer is no, and that's because the adenoviruses lack the ability to alter your DNA. They don't have the enzymes that are required to take that little gene and incorporate it into your DNA. What they do, as I said, is they deliver that DNA, they park it like a car in the garage, and then your own messenger RNA that you have in your cells comes along, makes the recipe, and takes it to the ribosome to make the protein. Next slide, please. So I wanted to put this slide in as a reminder, and that's because we really cannot lose sight that for COVID-19, the most powerful predictor of both serious disease and death is age. And the older we get, the more we are at risk of having serious disease or even death with COVID-19, which is why it's so important for us to get everyone over the age of 60 immunized as quickly as possible. So with that reminder, let's move on, and I'll tell you a little bit more about these vaccines. So we'll begin with the AstraZeneca vaccine. And the AstraZeneca vaccine and both the Jansen vaccines are similar in that they have not been tested in children yet. So both of these vaccines are for people aged 18 or over. You'll also see here they have not been tested in pregnant women. They've not been tested in women who are breastfeeding, and in fact, the Astrazeneca, when it was first authorized here in Canada, had very limited information on seniors as well. But both vaccines have been authorized for everyone over the age of 18. So that's who is able to use this vaccine. Next slide, please. These are the ingredients of the AstraZeneca vaccine. And some of these are stabilizers and emulsifiers and buffers, but as you can see, not a lot of exciting non-medicinal ingredients in the vaccine. I listed them here in case you have an allergy so that you can see what's in the vaccine. The nice thing about both of the viral vector vaccines is that they don't contain polyethylene glycol or PEG. That's the one that's in the messenger RNA vaccines that is sometimes a problem for people who have allergies to PEG. PEG is a laxative. It's also used in some cosmetics. And if you are allergic to PEG, and you would know if you're allergic because you wouldn't be able to use something like Restoralax, for example, which is PEG. And so that if you are allergic to PEG, you now have an option. You can use these viral vector vaccines. The other thing to note is that this vaccine does not contain any gelatin and it does not contain any latex either, if people are concerned about latex allergies. Next slide, please. So at the time that the AstraZeneca was authorized in Canada, and it was a few weeks ago now, the results of one of the phase 3 clinical trials that was being conducted in the USA were not yet available. So there was limited information on the vaccine. And in addition, there were some challenges in the clinical trials. There were changes in some of the settings for the trial. They changed from a 1-dose to a 2-dose regimen. There was an error in another place where they they gave too low a dose. They gave half a dose rather than the standard dose. And they were still recruiting seniors into the trial when the data was submitted for authorization. And at that time, there were just a little over 600 seniors in the data. So there was a very limited number of people over the age of 65. So because of that, when NACI, which is the National Advisory Committee on Immunization, and it's an arm's length volunteer expert group in Canada, when they looked at the research, they recommended that because there wasn't enough data with the AstraZeneca, they recommended it not be used in people over the age of 65. So that was the current recommendation in Canada, and was one of the reasons behind the provincial decision to use the AstraZeneca in adults aged 60 to 64 rather than in seniors. Next slide, please. So how effective is the AstraZeneca? Well, first of all, remember that this vaccine has 2 doses, and the doses are given anywhere from 4 weeks to 12 weeks, or 3 months apart. There were about 600 people who got vaccine in the clinical trials, and 6,000 people were given a placebo. So this was these were randomized controlled trials. And in the group that had the vaccine, there you can see the second bullet here, there were 71 cases of COVID. And in the group that had placebo, there were 186 cases of COVID. At 2 weeks after the second dose, you'll see that the efficacy was estimated to be about 63% in adults aged 65 and under, and 51% in those over 65. But you really can't you have to take that 51% with a grain of salt, because the number was so small. That is a very unstable estimate. And if you were to look at what we call the confidence limits around that, the confidence interval, they're wide. So it's really not a very stable estimate at all. The efficacy, though, with the AstraZeneca seemed to get better with people who waited longer between their first dose and their second dose. And that makes a lot of sense. We know this from vaccine science, that often the longer you can go between your first dose and your second dose, the better that second dose works as a booster for your immune system. So what they found in the AstraZeneca trials were that people who had their vaccine after 12 weeks actually had a better efficacy. They had about an 81% of the vaccine effectiveness. And then, as I said earlier, the estimates for people over the age of 65 just couldn't really be done. Next slide, please. So remember I told you about the low dose and the standard dose. Why? You may be thinking, well, why did that happen? And that's because it was an error. One group in the AstraZeneca trial received only a half dose of vaccine in their first shot, and this was due to a manufacturing issue, and it was then quickly corrected. So some of the research in the AstraZeneca is a little murky because of this error, and they report according to whether people had a low dose first or whether they had a standard dose. Next slide, please. What else did they see in the results of the trials? Well, they saw that there were no severe cases of COVID in the vaccine recipients. So even though the vaccine was maybe not able to prevent all cases of COVID, the cases were very mild. And so that's a really good thing to note. There were no hospitalized cases of COVID after the first dose. Actually 3 weeks, pardon me, at 3 weeks after the first dose, there were no hospitalized cases. There was one hospitalized case that was the day after their first dose, so obviously they were incubating COVID at the time, and another one at day 10, again, within the incubation period. So both of those cases had COVID at the time that they had their vaccine. But once the vaccine triggered the immune system, no more hospitalizations, which again is one of the important outcomes for a vaccine. And there was one death in the trial, and that was in someone who didn't get the vaccine, in someone who got the placebo only. Next slide, please. So I'd say there's pretty good protection in the AstraZeneca vaccine. I'd take it if I had a chance. And then earlier this week, NACI reviewed its recommendation, and that's because there were 3 new published trials. And these were preprints. They haven't been peer-reviewed yet. But nonetheless, they were all done in the UK, where there's been lots of variants of concern being transmitted. There's lots of B117 during these trials in the UK. The trials were actually done in older adults, in people in their 70s and in their 80s. And what they found was that there were fewer cases and hospitalizations in people over the age of 65, starting 2 weeks after the first dose, and that this worked just as well as with the people who were under 65. So same kind of efficacy regardless of age. In the study done, I'm at the fourth bullet if you're reading along. In the study that was done with 80-year-olds, one dose gave 80% protection against hospitalization or serious disease after 2 weeks or 14 days. And in the 70-year-olds, protection was as high as 73% by the 5th week after the first dose. So even without both doses, these vaccines were working really well. Next slide, please. So you might think, okay, the vaccine works, but how safe is it? Well, safety for the vaccine was assessed in almost 24,000 people that were in the randomized controlled trials. And so the vaccine, the Astrazeneca, was compared to the placebo, which for some people was meningococcal vaccine, and for some was just saline. It was a blank. And what they saw was that people who got the Astrazeneca vaccine, 74% of them reported pain at the injection site in the first 7 days. And remember how I told you, adenoviruses, they really get your immune system going. So that's how you know that the vaccine is working. Good to know is that these local reactions got better with the second dose. So they didn't get worse, they got better. And most of the common systemic reactions are the same ones that we see with many, many vaccines, including the Pfizer and the Moderna. Half of the people had fatigue, half of them had a headache. There was some myalgia, muscle pains, malaise, feverishness, not so much fever, but feeling feverish, and chills. In this group of 24,000 people, half of which got the vaccine, there were 2 serious events. One was someone who had a fever over 40.5, and one is a person who had developed transverse myelitis, an inflammation in their spinal cord. And this person who developed this was actually someone who had a very strong family history. Both parents and siblings had neurological disease. Next slide, please. So then I'm sure many of you have heard about what's been happening in Europe recently with AstraZeneca. First, I want to say that Canada is not using the same batches of the vaccine that were being used in Europe, and that to date, there have been no adverse events that have been received for the AstraZeneca vaccine in Canada. So Canada decided to continue using AstraZeneca while things got sorted out in Europe. And it's important to know that the number of reported thromboembolic events in Europe was not higher than what is normally seen in the population. But despite that, there were several countries that temporarily paused the use of the AstraZeneca vaccine as a precautionary measure while the European Medicines Agency investigated. So they did investigate. They met a couple of days ago, and then today have published their recommendations, essentially absolving the vaccine. And as of a couple of hours ago, as it's been reported in the media, several of those European countries are resuming the vaccination with the AstraZeneca vaccine. Next slide, please. So the big question, does AstraZeneca vaccine cause blood clots? Well, essentially, it's important to remember that blood clots happen, and especially in older people. And if you're immunizing older people, which all the countries are doing right now, you're going to see some people get blood clots. And so the COVID-19 vaccines are still recommended for people who've had a previous blood clot and in people who are receiving blood thinning treatment like Coumadin. And there really has been no evidence showing that there's a link between the Astrazeneca and blood clots. And that's after over more than 11 million doses. I think it's actually up to about 13 million doses of the vaccine. So important to follow up. Important to investigate, but it certainly doesn't appear that that these are linked to the vaccine. Next slide, please. Okay, so let's move over to the Jansen vaccine. And you already know a lot about Jansen because you understand how it works. May I have the next slide, please? So the Jansen vaccine is very interesting because it's using, as I said, a human adenovirus, which has been engineered so that it can't replicate. And this adenovirus, the serotype 26, is the same adenovirus that the Ebola vaccine uses. And so that's why you can see on this slide, there's been lots of experience with this particular virus. So vaccines, the Ebola vaccines have been given in almost 200,000 people, in elderly people, in infants, in a variety of races and ethnicities, in people who have HIV, who are immunocompromised, also in breastfeeding and in pregnant women. So that gives us a lot of confidence in this particular vaccine. Next slide, please. This is a map that's been created by the CDC, and it was done on February 28th, so about 2 weeks ago, and it shows in green where the clinical trials were done for the Jansen vaccine. And in navy, the map is showing you those places where there's been lots of transmission of variants of concern. So interesting that this vaccine was actually trialed in places in the world where there were many, many people being infected with the variants of concern. The slide shows the efficacy of the Jansen vaccine in preventing severe or critical cases of COVID in these different sites. So you can see that it ranges from a low of 82% vaccine efficacy in South Africa to 86% in the United States to 88% in Brazil. And some of this reflects the variants and the fact that they're a little more challenging, but still, nonetheless, still really, really good news for a one-dose vaccine. Next slide, please. How effective is it? Well, I've just showed you some of the data, and in all, there were about 40,000 people enrolled in these randomized control trials in various parts of the world. And I think what's really important about this trial as well is that 45% of the participants were ethnically and racially diverse. There were lots of Indigenous people, lots of people of color in this trial. As reported by the CDC and the FDA, the vaccine had different effectivenesses depending on where it was. Interestingly, the studies showed that it was most effective in the US and least effective in South Africa, with efficacy of 64% after 28 days. So that's what's reported in the clinical trials, which is a little different than what's being reported in the CDC. So I'm wondering whether the CDC is actually getting data further down along the road, longer than the 28 days that were used for the trials and submitted for authorization. In the vaccine recipients, there were 66 cases reported of COVID, and in the controls there were 193 cases reported. So that's where you see the efficacy, 67% after 14 days, and I took a range from what I was reading in the clinical trials from 66 all the way up to 85% after 28 days. So by 4 weeks, the vaccine's working really well and able to prevent moderate to severe disease. Now, unlike the Astrazeneca vaccine or even the Pfizer or Moderna, where there have been millions and millions of doses administered, we're still waiting to see the real world data on the Jansen vaccine. We just don't have a lot of that yet. Next slide, please. What are the ingredients? Well, again, they're a combination. Citric acid is an antioxidant. There's ethanol, which is alcohol, hydrochloric acid, polysorbate 80 is a stabilizer, sodium hydroxide is a desiccant, it absorbs moisture, trisodium citrate dihydrate is a buffer. So not a lot of interesting or pretty, allergenic items. No gelatin. No. Again, I believe this is latex-free as well. I'll have to check on that. And again, there's no PEG in this one as well. Next slide, please. How safe is it? Well, they did a safety analysis as part of the authorization on almost 44,000 participants that were in the randomized controlled trials, and they took a subset of that group. They looked at just under 7,000 people. Half had the vaccine and half had the control, and they looked at both the solicited events where they ask you to tick off which side effects you have, and the unsolicited adverse events where people had to say voluntarily told them, well, I felt chills last night, or I felt dizzy this morning. And what they found, very similar to the other COVID-19 vaccines: injection site pain, headache, fatigue, a little less. This one looks a little less reactogenic than the Astrazeneca and even the Pfizer and the Moderna. So I think that it looks like the side effects are less with the Jansen, at least from the clinical trials. The younger you were, the more often you had an adverse event. So if you're older and you're getting this vaccine, you might not feel it as much. And in these 7,000 people, there were 3 serious events. There was 1 case of fever. There was 1 injection site pain that was quite significant. And there was 1 person who developed a rash and some swelling of their lips. Next slide, please. Other events of interest. Well, when you're looking at blood clots, they found that there were in 15 vaccine recipients and in 10 of the placebo, and this was not significantly different. 13 vaccine recipients complained of vertigo, and so did 7 who got placebo. I found this really interesting. 6 of the vaccine recipients had ringing in their ears as a side effect. That it went away, but that was a very interesting one. Seizures in 4 of the vaccine recipients and 1 in the placebo recipients. And in all of these events of interest, they could not establish a causal relationship. There was a temporal relationship in that they happened within the, several weeks of having the vaccine, but they weren't able to prove that they were related to the vaccine. Next slide, please. So some of the questions you might be thinking is, well, can I take these viral vector vaccines if I have an existing health condition, such as diabetes or high blood pressure or hepatitis or HIV? And the answer is yes, please. Please be immunized with whatever vaccine you can get first. All of the COVID vaccines can be used by people who have chronic conditions. Existing health conditions are just one more reason to be immunized. And people with underlying conditions that increase their risk are going to be included in phase 2 of our vaccine rollout. Next slide, please. Just to give you an idea, in the Jansen study, when you looked at the participants, 40% of them had more than one risk factor for severe COVID disease. So they had more than one underlying comorbidity. 29% of them were obese, which is a risk factor as well. 10% of them had high blood pressure. 7% of them had type 2 diabetes, and 2.3% had a serious heart condition, and yet they all benefited from the vaccine. Next slide, please. So what are the plans for the Astrazeneca and the Jansen rollout? Well, the answer is you're going to have to stay tuned, because we need, first of all, there's been a change in the NACI recommendations when it comes to AstraZeneca. So don't be surprised if in the next couple of weeks, Ontario makes a decision to make AstraZeneca available and recommended in seniors as well, which means that potentially seniors may be able to get their vaccines from the pharmacy or from family doctors as well, because these vaccines are great vaccines for pharmacies and primary care. They're stable, they're refrigerated vaccines. We still don't have a NACI recommendation on the Jansen vaccine yet, so we're still waiting for that one. Once NACI makes its recommendations, it's up to the provinces and the territories to make their decisions based on the NACI recommendations. And then once Canada gets the vaccines, they allocate them to the provinces and the territories, and that's when they make their way into your arms. Next slide, please. Can I take Tylenol or Advil before my shot? So because these vaccines are associated with tenderness and pain, people are wondering, should I take something before I get immunized? The answer is no. Don't do that. While there hasn't actually been research done to whether or not on the COVID-19 vaccines about whether taking Tylenol or Advil ahead of time affects your immune system's ability to react, we don't know, and so we don't recommend it. So to ensure that the vaccine works properly, don't take Tylenol or Advil before your appointment, and just wait until you need them. If you really need Advil because you've got muscle aches and you're feeling miserable, take it then. Let that immune system get activated first, and then use these medications as needed. Next slide, please. There's been a lot of, I think, controversy and concern about the fact that the second dose interval has been extended in all of the COVID-19 vaccines. And you may have heard that first NACI recommended that based on the data from around the world, that that one dose was good enough, was giving 70 to 80% protection after 2 weeks, and the need to get people immunized to protect them, especially now that we have the variants of concern. So NACI did make that recommendation, and then Ontario did decide to extend that second dose interval to up to 4 months with very few exceptions. There are a few exceptions, but for the most part, we are all going to have to wait for up to 4 months. If we get loads and loads of vaccine, that interval will be shortened. And so we'll just have to wait and see. But as I said, as far as the Astrazeneca vaccine goes, there's really good evidence to show the longer you wait for your second dose, the actual better the vaccine works. So I don't think we need to be too concerned about extending that second interval to 4 months, or 16 weeks. Next slide, please. What is the timeline for the phase 2 rollout? We are just about to finish phase 1 here in Peterborough. We've got about another week and a half to go to get all of our populations in phase 1 done. And then we'll begin phase 2. And phase 2 really is contingent on having lots of vaccine. So we need to have that vaccine flowing into Peterborough. We'll begin with adults aged 79, working our way down to age 60. And the province was saying we were going to do that in 5-year intervals. That might change. They may break it up into smaller intervals so that we don't crash the booking system, which has happened in most provinces. Also, we will be doing the high-risk congregate settings. So those would be the shelters, the group homes, correctional facilities. We will do people who are younger than 60 who have a high-risk chronic conditions, and the ones at very high risk, their caregivers, their household members, caregivers will also be done. And then we will do the people who cannot work from home, everyone from people who work in the funeral industry to teachers to essential workers like police and firefighters, grocery store workers will all be done in phase 2. And then there is also the opportunity to do at-risk populations. That isn't such a big one for us here in Peterborough, but certainly in our large urban centers, there are neighborhoods where there are very high rates of infections, where there have been many deaths. And so those large cities are able to prioritize those at-risk neighborhoods as well. And I foresee that the pharmacies will also be another way to do that. Phase 3 is when we get to enough vaccine for anyone who wants it. Lots of vaccine at your doctor's and nurse practitioner's office, lots of vaccine at the pharmacies, and we hope to get there by July, and that's when anyone, adults 59 years of age and younger, will be able to get their vaccine. Next slide, please. You may be wondering what are those chronic conditions that are going to be done in phase 2? And here's a list of them. The province has divided it into 3 groups. The highest risk group, which would include people who've had organ transplants or people who have had stem cell transplants, people who have neurological conditions that really put their breathing at risk, people who have malignancies of their blood system, and people with very severe kidney disease who are on dialysis. Those are the highest risk groups. Then there is the high risk group, and you can see people with obesity, people who are immunosuppressed because they're on chemotherapy or they're taking some kind of treatment that suppresses their immune system, or people with intellectual and developmental disabilities like Down syndrome are in the high risk group. And then there is the at-risk group, and they believe there are about a little over 2 million Ontarians in this group, and there's a bit of overlap, of course, with people who are older, but that would be everyone from someone who's pregnant to someone who has diabetes or dementia or other chronic diseases. So those are the groups, and I am expecting to get a little more guidance on these groups and also how and when they'll be done from the province in the next week or two. Next slide, please. How will these chronic illnesses be verified? How will the caregivers be identified? So as I said, we don't know yet. We are waiting for some phase 2 guidance from the province. My hope is that it'll be the specialty clinics, so that if, the GAIN clinic or the dialysis unit or the cancer center that will identify people who are eligible, as well as their primary care providers who have their medical record, have their diagnoses, and are able to both identify and also administer the immunization. So the good news is that here in Peterborough this week and next week, our primary care practices are piloting the Astrazeneca vaccine, and they're learning all the logistical intricacies that is required for them to be able to administer the vaccines. And so hopefully by the time we get the guidance and we get additional vaccine, we'll have lots of people in Peterborough who can help immunize. Next slide, please. What's the plan for chronic home care patients? Well, we are actually doing that outreach now to home care patients. And again, there's a bit of overlap with the chronic conditions. We do have many home care patients who are residents of retirement homes or in congregate settings. And so we've been reaching them already through mobile clinics. There is a small portion of home care patients who are homebound and living in the community, and we are in the process now of determining who they are so that we can transport a single dose of vaccine to the home with a healthcare provider who's able to immunize them. And then for the remainder of that population, we've been piloting an outreach strategy. We've been using robocalls to reach them, having them contact us so that we can book them into our clinics. And we have clinics scheduled next week for this population. Next slide, please. When can I get an appointment, and how will I know which vaccine I'm getting? So Canada is very unique from most jurisdictions in the world because we really have a multiple vaccine strategy with lots of different vaccines. And currently in Peterborough, our mass immunization clinics are providing either the Pfizer or the Moderna vaccines, those frozen ones that can't be moved very easily. But that might change. We might get Astrazeneca in a few weeks. We don't know. When you book your appointment, right now, the booking system does not tell you which vaccine you'll be getting. So essentially, when you come to the clinic, you will be told and you will be asked to provide consent according to the vaccine that is being used that day in the clinic. In addition to that, the pharmacies and the primary care currently are piloting the Astrazeneca. So we know that's where the Astrazeneca is right now. We know where the Moderna and the Pfizer are right now, but all of this is subject to change in the next weeks and months. Next slide, please. That's the end of your questions that you submitted. So thank you for all of you who did send those questions in. And we can now open it up to questions from those of you who are with us tonight. So over to, I believe, Sarah.
Actually, it'll be me, Dr. Salvatierra. It's Brittany. So I will spotlight you up on the screen for everyone. And we have received some questions through the chat thread, and I will read them off to you. So let me just find them here. Okay, so we're going to start with Elaine Trotter. She is asking, have there been studies that prove we can wait 4 months for the second AstraZeneca dose?
No, so the AstraZeneca is 12 weeks, that's 3 months. And so the studies, that's the longest that the studies went. The 4-month interval that's being recommended by NACI for all the vaccines, based a little bit on what we know about vaccines and the fact that we know that you can usually lengthen that interval and actually get better results when you do so. And also from the real world experience, which shows that the one dose is enough to give people protection. So the decision to go with the 4 months is really based more on the issue of equity, trying to get as much vaccine out to as many people so that the majority of people can be protected sooner, and then going back and doing those second doses when there's more vaccine.
Okay, thank you very much, Dr. Salvatierra. Okay, someone with the handle It's One Shot is asking, when will parents of children with cystic fibrosis get vaccinated in Peterborough?
That's a really good question. So as a caregiver of someone who is at high risk, you could certainly see why that makes sense. I'm going to suggest, Brittany, that we write that one down, and that might be a question we can take to the province. If it's not in the guidance for the phase 2, if we don't see it, it might be something we can ask about.
Okay, great. I've flagged that already for us.
Great.
Great, thank you.
Thanks for that question.
Okay. Okay, Kathy Brown is asking, for the Pfizer and Moderna vaccines, is it effective in 2 weeks? How long for the Astrazeneca and the Jansen vaccines?
With most vaccines, it's 2 weeks. And in fact, even with the Astrazeneca, it starts to work in 14 days, in 2 weeks. But if you read the product monograph of the Astrazeneca, it says 3 weeks. And I wondered when I saw that, I thought, what's different about the Astrazeneca? You know, how is it different from every other vaccine? And the reason why they say 3 weeks is because at 3 weeks, there were no further hospitalizations. So they say that by 3 weeks after your first dose of AstraZeneca, it prevents hospitalizations. So in order to say that, they had to use the 3 weeks. But in reality, all the vaccines start to work after 2 weeks.
Okay, so we will move on to Nancy Wood, and she is asking, are there side effects that we should be concerned with for over 65? She hasn't specified a vaccine.
I mean, no, I think what you need to do is expect that there will be side effects. The vaccines don't stay in your body for very long. They're gone really in a few hours to the most a few days. And so most of the reactions that we see are in the first 7 days, and there tend to be a mixture of local reactions and systemic reactions. I think if you are concerned about a reaction, the first thing to do is to contact your healthcare provider and let them know, because we as healthcare providers do have an obligation to assess and document all of the side effects, because that's how we do surveillance. We learn from vaccines when we're giving them in large numbers by studying their impact and tracking the kinds of side effects that are being seen. So it doesn't hurt to, if you're sick enough to see a doctor, it doesn't hurt to do that. And then your physician or your nurse practitioner will fill a form out. There's a form they have to complete. They give it to me, and I look at it as well. We report to Public Health Ontario. At the end of each week, Public Health Agency of Canada reports all of the adverse events for all of Canada. We track them, and we do additional kinds of surveillance as well in order to make sure we are assessing and monitoring the vaccines for safety.
Great, thank you very much, Dr. Salvatierra. And we do note on our website links to the Health Canada page for adverse events following immunization, so people can see that and see how it's tracking and how low they actually are. Okay, Ron Carveth has a question. He's asking, how many vaccines will Peterborough receive each week for the next month?
Well, for the next month, we're getting about 5,500 to 6,000 vaccines a week. And so we are hoping to immunize at least 1,000 people a day. We have asked for additional vaccine to the province so that we are able to get vaccinate as many as possible. And we've been told that those numbers are they're not the ceiling, they're the threshold. So they're the minimum we will get. So I'm hoping that we'll actually get more. And the sooner we get more vaccine, the sooner we can start to immunize people under 80. We expect to be done all of the 80 and plus in Peterborough. We expect to have them all done by next week. And then as soon as they're done and we do the home care patients, then we can start with the younger age group.
Okay, thank you. And Dr. Salvaterra, we're at our time. But there are a few more questions. Do you have a bit more time for us?
Sure. Hey, I have no life but COVID.
Okay.
Go ahead.
Okay, so we have Sandra Orsatti is asking, is it better to go with the AstraZeneca pilot for 60 to 64 now or wait for a possible mRNA vaccine later?
I'd say take the first vaccine you can get. So if I was offered AstraZeneca today, I would take it. And that's because it's a good vaccine, and the sooner you're protected, the better. Especially now, we're really worried about a resurgence of cases with the variants. We know we have variants here in Peterborough. In fact, most of our cases are variants now. It's so transmissible. So I'd say go for whatever you can get and get it as soon as you can.
That's great advice. Thank you. Okay, Nancy Wood had asked another question. Any idea when the Jansen vaccine will be given?
It's a mystery. I have not found anything on the Jansen in Canada. I don't know, maybe our MPP, Mariam Monsef, has a better line of sight on the Jansen product. We haven't been told here in Ontario when we will see Jansen. And as I said earlier, we haven't even seen the NACI statement, which so there aren't even any recommendations yet as to how it'll be used. So no idea on the Jansen. It's a bit of a mystery. But at least now you'll know about it. And as I said, the nice thing about it is it's a one dose. So, you don't need to come back. Certainly for groups, for people who are hard to reach, it's a great vaccine because it's only the one dose and you're done.
Okay, great. Okay, Ed Leardom has joined us and he has a couple of questions. The first one is, my GP retired in December. I don't have a GP now, but I do have some at-risk conditions. How can I be included in phase 2 of the rollout?
Well, you don't need a physician. We still haven't figured that piece out, and we still don't know yet how the chronic conditions are going to be done. As I said, my preference would be that physicians and nurse practitioners identify their patients. But you're right, if people don't have a nurse practitioner or a physician, that puts them at a disadvantage. We would have to find a way to do that, or there may be a way to do some kind of attestation at the time of booking. So still don't know yet on that one. Give us a few weeks and we'll get that one sorted out.
Thank you, Dr. Salvaterra. And we do have information on our website for the virtual care clinic that is offered through our partners, the Peterborough Family Health Team, and they are able to do vaccine consultations with those who don't have a GP. So. And
that's actually a great suggestion, Brittany. That virtual care clinic, if it turns out that you need to have a physician identify and potentially immunize, that virtual care clinic would be a perfect resource for the community, for people like the person who asked the question. I forget his name. I'm sorry.
Ed. Ed.
Yeah. Ed. For Ed, that would be a great solution for Ed.
And Ed did have another question, and this is a good one. Can you get a first shot of one vaccine and a second shot of a different vaccine?
That's the $1 million question. That there is actually a clinical trial being done now where they're trying that. They're going to mix and match the vaccines to see whether you get even better results potentially by using different triggering your immune system in different ways. And it's interesting because the Sputnik vaccine in Russia, they actually use a different viral vector in the first dose than they do in the second dose. So it's very fascinating. They've actually used two different vectors for their vaccine. And I think as a way to try and see if you can make that immune system work a little harder.
Okay, thank you. So Vivian Sim has a question. She said, we've had AstraZeneca vaccine. Will the same pharmacy inform us when the second dose is available?
I would hope so, but you don't need to worry. Once you're in COVAX, so the pharmacies as well as primary care and public health in the hospital, we're all using the COVAX Ontario system. And once you are entered into the system, you've been given vaccine, that becomes your medical record, and and that tracks you according to which vaccine you have. It'll track you to let you know when you're due for your next dose. So we'll see how that part works. I haven't actually seen that part. I haven't seen that working yet because we're just giving first doses here in Peterborough. But I believe that that's what's supposed to happen. And hopefully by the time you're due, we'll have AstraZeneca in pharmacies here in Peterborough as well.
Okay. Great, thank you. So Ed Leardom did have another question. What happens if we refuse the vaccine offered to us at an appointment?
Well, I guess you don't get vaccine. It's your choice. And, and when you're going to the clinic, you're making you're giving informed consent. So it's really your choice whether you want to be immunized or not. And I'm hoping that people will take whatever vaccine is on offer, just because I still don't know, at least now in early days, it's going to be choice. Perhaps by the time we get to July, there may be more choices for people who are younger, who aren't at risk. They may have more choice. And then, of course, once we're into this, a year down the road, when we know about whether you can interchange the vaccines, when we know whether or not you're going to need a booster, depending on what happens with variants of concern and whether the vaccines are going to need to be changed, and then we have to take, get another dose. There may be more flexibility there, but I think right now in these early days, it really is whatever you get, you should take.
Okay, thank you. So now we have a question from James McCatty, and he's asking, the province is talking about all eligible Ontarians having the vaccine by the first day of summer. Why does the timeline in Peterborough go well beyond that?
Well, you may be looking, it depends which timeline you're looking at. I know we did some original projections and we have sort of our Peterborough plan and we have it mapped out, but it hasn't been, I don't think it's been updated. Once the province made the decision on March 8th to go to 4 months as the interval, everything gets shorter. And because we're not giving second doses and we're just giving first doses. So we'll get through the populations sooner. And I don't believe our placemat's been updated, but Brittany, that's something we can check with Jane tomorrow. And then we probably need to get a revised version up on our website.
Good, great point. And so I've flagged that as well.
Great.
Okay, and that I understand is the last question in the chat. So we've done it, and thank you so much for your wonderful wisdom and excellent questions tonight from our audience. This has been a very informative evening. This live stream has been recorded and will be posted on the Peterborough Public Health YouTube channel, so it will be available for any who may have missed it, or if you want to refer back to it, it'll be there for you. So thank you, everyone. Thanks for joining us this evening, and have a great night. Take care now. Bye-bye.